My name's Callum, and Ben is also going to be presenting today. So we're going to talk about Ramsay Health Plus and men's health. So what do we offer at Ramsay Health Plus? So continuity of client care throughout your patient's surgical experience from preoperative to postoperative, and this is with men's health, and Ben will talk a bit later about the other services that we offer. We offer structured exercise programs and advice to help the patients achieve their goals. And you can see, like, this is the facility that we use. We've also got a large rehab gym, so if we need to use any of the bigger machines, we can do that as well. And we offer patient education of where to locate appropriate and relevant health information as well. So I'll talk about pre-op prostatectomy physiotherapy. So the main purpose of Prehab, and there's a lot of growing evidence to support this, is to improve post-operative functional capacity, the trajectory of recovery from urinary incontinence, patient well-being and quality of life. And the benefits have been reported from a structured Prehab program, including reduced BMI, waist circumference, anxiety, and then improving 6-minute walk test distance compared with controls. And the AUA and the SUFU 2019 guidelines for incontinence after prostate treatment suggest starting preoperative pelvic floor muscle training 3 to 4 weeks prior to surgery. So if I see someone pre-operatively, what I'd like to get them doing is start them up with a bit of a program so they can work on their aerobic capacity, resistance training, and start them doing their pelvic floor muscle training earlier before they have the operation. I say to them, have you started any pelvic floor muscle training before? Do you know what that is? Some of them are good and they say, yeah, I've been doing it all the time. I'm like, great, that's really good. But some people will be like, oh no, I haven't really heard of it, or they've heard of it, but they haven't really been committed to doing it. So it's good to get the patients in so we can set them up really well so they get better outcomes after the surgery. And there was a great study by Mugovan. I'll put my references down at the end, so if you're interested in having a read, you can look them up. So they had their surgery and then they're coming to me post-op after their prostatectomy. So our goals here are to change the pattern of recruitment with a focus on the anterior pelvic floor. So what we want to do there, rather than just saying, okay, can you think about doing your pelvic floor exercises, we really want them thinking about their striated urethral sphincter, and to do that we want them to think about, okay, can you think about stopping the flow of urine midstream? That's one way to get all the attention at the front, because we have better outcomes doing that rather than saying tightening up your glutes and your rectum at the back end. So if we want to tell our patients, okay, always thinking about the front. Another cue that you can use for that is trying to lift up the testes, or some people might say, and it might stick with your patients a bit easier, to say nuts to guts. I've heard that one before. And the other one is if they can think about trying to contract or retract their penis as well. That's another cue that they can use for that. We want to integrate pelvic floor muscle control into functional tasks such as sit to stands, lying to sit, and the other way around, walking, and then increasing their bladder control throughout the day into the afternoon. So that's really important, rather than just getting them to sit or lie down and do their exercises. What you're going to be doing mostly, or when you'll find the incontinence, is when they're walking around or they're standing up for the first time and they haven't thought about contracting. And then progressing towards managing higher intensity or unexpected demand. So quite often people say, I was coughing, or I was at work and I had to pick up something a bit heavier and then I had a bit of a leak there. So what can we do about that? And I've included a little bit of a practical time here, seeing as we've been sitting for a little bit. I'll get everyone to stand up, please. Alrighty. So you probably didn't have a thought of, okay, before I stand up, or maybe you did because I just mentioned it before, but you might not have tensed your pelvic floor before standing up. So I'll get everyone to sit down again. And then we'll try again. So think about contracting your pelvic floor using those cues that I was talking about before, and then everybody stand up again for me. This is good. It's like my own exercise class. And now I want everyone to think about when they were, using their pelvic floor, were they overactivating their abdominal muscles? If you were, then you might have to do it again and retry it. Or did you stop breathing when you were activating those muscles? And if you're trying to hold, if you stop breathing, you're increasing the amount of pressure that you have for the pelvic floor to fight against. And if you've got too much pressure in the bladder, and if that's higher than the pressure that you can generate outside the bladder, then you're going to have a bit of a leak there. So I'll get everyone to sit down again. Thank you. A couple of sit-to stands to make your day go better. So what does a typical session look like if someone comes to see me post-operatively? So this would be a review session, not the initial. So discuss the progress with the exercises and continence, and we check a bladder diary as well. I think these are really good because on there they can write down when did they have any incontinence or leakage of urine. And they have a little note section here. This is from the Continence Foundation of Australia. I think it's a great one. My patients use it. They can write down, say, I stood up after sitting and it was late afternoon. I just lost control and had a bit of a leakage there. So then we can target and say, okay, maybe you need to really work on your sit-to-stands with pelvic floor control prior to that activity. They can also write down how much pad weight they've got, so measuring a dry pad, and then they can weigh that one, weigh it, and then after they've had some incontinence, if they're going to change, they can weigh their wet one, and we can see what the difference is, and we'd like to have a look and hopefully see a decrease in time as the weeks go by. Discuss strategies for correct pelvic floor muscle use, so self-palpation, visually, having a look like those cues that we saw about raising the testes, or can they retract the penis, or doing a flow stop as well, which is when they're going to the bathroom. If they're able to stop the flow midstream, that means they're using the right muscles, but I don't encourage my patients to do that on every single time they go to the toilet, because we don't want to encourage any bad bladder behaviours. We want them to void fully when they are going to the bathroom. We'll discuss the progression with pad weaning strategies, or if they're getting particular urgency or stress incontinence. Check their pelvic floor exercises and see what their technique's like. So are they breath holding, or are they contracting their abdominal muscles too much? And then progressing the pelvic floor exercises, or adding some body weight exercises as required as well. And then following there, we can offer a lot more as well. So the Clinical Oncology Society of Australia put up some recommended guidelines for continuing physical activity. So all people with cancer should avoid inactivity. So as we heard before in the previous talks, like yesterday, some exercise is good exercise, and if we can encourage that, that's really, really good. But their recommendation saying at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic exercises, or and 2 to 3 resistance exercises sessions each week, which is moderate to vigorous, targeting the major muscle groups. It's good to find an activity that your patients really like as well. So if they're a keen golfer, or if they've got interest in sport, trying to make it really relevant to them, because if you have an exercise program that they don't really want to do and they're not really engaged with it, then they're not going to want to do it. So make it really patient focused. The other thing that I like to do is guide my men's health patients towards some good resources that they can use. So the Prostate Cancer Foundation of Australia is great. They've got a lot of little booklets that patients can use or have a look at on the internet. The Continence Foundation of Australia as well, and I believe they have a helpline too. and just even the Australian Government Department of Health. So they've also got some guidelines for like how much exercise should you be doing for different age groups. I did whiz through that one, but there are the references that I was talking about before. They're really good. Did anybody have any questions before I move on? And yes, Ben.
What's a realistic time frame to see improvements? Are you talking weeks or months?
So it does depend on how the patient was pre-operatively as well. So if they have incontinence, then it may take a little bit longer. But what I've been doing is I've been chatting to the urologists and the surgeons, and they have different time frames of what they would like. So if someone hasn't really improved within a year, they may offer like an alternative surgery to help with their incontinence as well. Yes.
What's the sort of program is that, apart from bringing it into daily life and just sitting to stand? Like,
yeah.
What is it, like 5 minutes twice a day? Or?
It depends where they're up to. So do you mean in terms of just pelvic floor?
What bonus you're putting on patients? What do you is it twice a day?
So what I like to tell them to do, and there has been a recent study.
These studies, what did they say was effective?
Yeah, so Joanne Milios in 2019, she had a trial with 97 men. And they were split off into groups, and they did 5 weeks prior to surgery, and it continued for 12 weeks, and this was for a radical prostatectomy. She showed that the control group had slower return to continence and increased leakage compared to the intervention group, and the control group, I believe it was just 3 lots of 10 pelvic floor holds, but with the intervention group they did slow holds for 10 seconds, and they did also 10 fast contractions as well of the pelvic floor, and they were looking at 120 contractions per day in a standing position. So what I tell my patients is if you can plan out time throughout the day, because I'd rather them work on it morning, evening and night time, trying to fit in pelvic floor holds, and I'll say to them when you're first trying to figure out how to do your pelvic floor exercises, it's going to be a lot easier in a supine position or sitting as well, and then you can progress to standing if they are struggling with that, and then trying to work in it could be 10-second pelvic floor holds, maybe you want to do 5 or 10 at this particular time, and try to work it throughout their day, and then once they get to a point where they can use their pelvic floor quite well, then we can start adding in some faster contractions throughout the day as well. Does that answer your question?
Yes, it does. And also the other thing is, question I've got is, do you have any experience with these magnet chairs, Tesla coil chairs that are quite wide?
No, I haven't. You can elaborate on that, I'm sure.
I can't remember the names of them, but I've seen them at various conferences where they chairs that you sit on, and they have magnet devices to stimulate the muscles. So basically it's not TENS machines because there's no pads or anything, or there can be pads, but they're through the magnetism of the chair, much like the cranial magnet stimulation. They stimulate the muscles. It's an incontinence treatment.
No, I haven't, but I'll look into it and see what their wave brilliance. Okay, no, I can look into it and have a look. Yeah, but I haven't heard about it until now.
More popular.
And seller, or there's a few different ones out there.
Not sure on the research on that one, unfortunately.
You'd have to suspect that it's a bit passive.
Oh yeah.
That
It
couldn't be as good as active exercise.
Exactly, yeah.
But if people do it, because it depends how motivated they are.
And then it's like we also want to integrate it into the pelvic floor exercise into meaningful tasks for the person. Even if it's they're getting down the track, and if they're really keen in for golf, and when they're doing their downswing, they might notice some incontinence from the increased pressure through the swing. You might not get that from just sitting sitting down. Did you have a question?
What the cost involved? It's like a duty package or?
Ben is going to talk about that. Yeah, so I'll get him to come up, and thank you for listening to my. Oh yeah.
In the pad.
Good morning everyone, I'm Ben. I also work at John Flynn as one of the physios, so I'm here to talk mostly about Ramsay Health Plus, but I will be talking a bit on orthopaedics and following on from Dr. Tudor with hopefully some time at the end for some practical demonstrations to make it slightly more interesting. So at Ramsay Health Plus we have access to all the allied health team that we have in the hospital, so physiotherapy, occupational therapy, speech pathology, dietetics and exercise scientists, we have all those. And psychiatry, when we can get a psychiatrist, that'll be available as well. In terms of the treatments, physio treatments, the main ones are all listed up there, but obviously the other disciplines have their treatment options as well. At the moment it's mostly pre and post-op, particularly orthopaedic patients, but being a maternity ward we do all the women's health and women's care pre and postnatal. Men's health obviously is a growing area that we're trying to build on at the moment. We can do the lymphedema training, so the bandaging for lymphedema patients, which is a rarity and hard to get patients into on the Gold Coast at the moment apparently, so we are one of the options that can do that. We also do cardiorespiratory physiotherapy, so I do a lot of work in intensive care, and so I get patients referred to me from the hospital as well as our respiratory physicians. And helping with the preventative managers, especially bronchiectasis, so the flutter devices and the inspiratory muscle trainers. So again, it's often hard to find a respiratory physio on the coast, so we have that ability here at John Flynn. So in particular, I wanted to touch on prehab for joint replacements, in particular hip and knee. As we know through the research that those who have more strength prior to surgery not necessarily have better outcomes 9-12 months down the track, but certainly that 1 to 2 week starting period post-surgery, they have a much easier time, particularly with those functional tasks of getting in and out of bed, standing, using crutches, which means they can get home sooner and a less burden for the hospital as well as their family. So bringing them into physiotherapy, ideally 6 weeks prior to surgery, but even 2 weeks makes a good difference, to try and get their particularly quad strength improved and get them through functional tasks, such as going from in and out of bed, using their abdominals more, not relying on using their operated side as much. And in particular for the foot surgery patients, if they're going to be partial weight bearer or non-weight bearing, it's particularly important to try and get them into prehab so that they can learn to use crutches, because trying to teach a 70-year-old to non-weight bear who hasn't hopped since she was 20 and still thinks she can is a very difficult task, particularly if she has stairs at home. So it's sort of a wake-up call for a lot of patients, realising exactly what the rehab post-surgery is, so that they have time to prepare, get their upper body stronger so they can cope and be safe at home, and we don't have any mishaps, falls and readmissions to fix another fracture. So some of the feedback we've had there from patients is didn't know that they couldn't hop anymore. It's been a long time since they had. We have all the equipment there that we would use in a hospital and prescribe at home, so the forearm support frames, crutches, hopper frames, scooters, wheelchair fitting, stairs to practice, so we go through all of those options to find out what best suits them in terms of the size of space in their home and what help they have, stairs, all that's taken into consideration, so they can have a practice on all of those, because not many people have seen the knee scooters, which does make life a lot easier for those particularly going a bit of distance, not just around the home, but to see family and friends and keep them mobile in the community. And others realise just how hard it is and tiring to get across the room non-weight bear, so they will get their family to help rather than having to stay at rehab or going to respite for those weeks for no real reason other than they didn't think ahead and plan some help from their family. So coming into the costing, so an initial, it works the same as any other outpatient department, private physiotherapy clinic. where there's initial consult, so that's usually 45 minutes at $90. If there's a group class, $30, that's up to 4 people. Individual 30-minute reviews, which are at $75. And whenever we book in patients, we tend to mention the CDMP, or EPC it used to be called, which contributes $45 towards the cost. So a lot of patients might come asking for that. I'm sorry, I know it is a lot of paperwork, but it does mean that they're more compliant, because obviously costing is one of the major issue in having compliance with patients coming back for appropriate follow-up. And in particular prehab, because they don't think they need anything beforehand, so they'd rather save their money for afterwards, which we know it's good to have pre and post. So certainly the benefits of Ramsay Health Plus, so being at John Flynn, it's the continuity of care that you can't get with other physiotherapy. So as I said, you have the same physio pre-op. Because I work in the orthopaedic department, I see them in the hospital as well. So they're the same face, giving the same information all the way through, and then we see them post-op as well in the clinic. A lot of our orthopaedic surgeons have rooms in the hospital, so we time the physio reviews at the same time as their surgeon, so certainly at the 2-week and 6-week mark. And so it's just that ease of access. There's competitive price as well as access to the surgeons, so we often see our orthopaedic surgeons doing their rounds and ask questions and follow up with them if there's any concerns. It just makes it easier having that working relationship, as well as I said, the full team of allied health for those complex cases, which isn't always available at other clinics. And so referral process, like any other physio department, you can just come without any referral, so the patient can just call up and book in. Certainly if they have a planned surgery and prehab, it's better to have that EPC or CDMP form filled out, so that's where you guys come in. But yeah, call up, or we have referral pads outside as well if you want to put some more details on, or you want to be specific of what you want with the different disciplines. Then you can circle those, tick whatever you want to get the best for your patient as well. So those referral pads are available outside if you'd like them. Well, that's just our motto. Are there any questions about Ramsay Health Plus? How am I going for time, Naomi? Oh, yes, absolutely.
I'll just very quickly say that I don't know how long you've been running for now, but as a clinician who's worked with you and you guide your team, but specifically you've done an amazing job for every single patient that has come through. So I can really recommend the service that they provide. It really is a very good service with excellent communication with us as clinicians.
Yeah.
Feel the love.
Yes, it's nice. So after each, certainly the initial session, we send out a letter, everything that we've come to find out about the patient and what we're going to focus on over the coming weeks. And then certainly at the end, we give you the letter as well. At the moment, while we're not too busy, I tend to send a letter after each session just to give you the update, but there can be as much information as you like. Obviously, I know you're very busy as well, so less information coming at you, the better sometimes, but it is good to know that it's available. Sorry, how much time?
Couple of minutes.
Okay, well, let's do the important ones then. So Anne yesterday said that she wanted to be a little bit more active, so she's agreed to be my model. So if you would like to come up, Anne.
She's at the swimming pool.
So this follows on quite nicely from Dr. Tudor's. So we're just going to go through a few of progressions that we might do with a patient to show that they're ready to progress on to the next stage. So limited with attire, so what we might start with is just the very simple, so single leg stance, so we're just standing on one foot, trying to maintain balance. Alright, so we've got 3 people who are maintaining control with just control through their ankle, and one person who is maintaining control
Flailing around.
with their upper body. Okay, so we've lasted the 30 seconds, all right, but we get a tick for 3 of us, and one would get a half a tick there. You can work out who that half a person is. All right, so we would progress that by putting them on a Duradisc, all right, and then making them move their ankle forward, back, left, right, so that they have that control as they move. All right. So our next progression is then moving on to inside their base of control. So if we stand on our one leg again, and then we're just reaching in forward, side, up. All right. You can do both hands, absolutely. All right. All right. Good. All right. So that's in. So that's inside our locus of control. So then we move on. So we're doing that quite well. So then we go to what we call an external perturbation. So something that you're not controlling. So Anne, if you'd like to face me, all right, standing on your foot again, all right, and then you need to catch the ball. Okay, and toss back. All right. So we're going outside her base of support. And it's something that she can't really plan for, so you can see it makes it a little bit more difficult. We like to come. Let's all have a go.
Let's all have a crack. You can throw the ball if you like.
All right, so we're getting a little bit harder each time, so going high and low as well as out to the side, and then on to... and then our last one, if we take a chair, we have a limited time, so we would normally do this on the arm of the chair, because we don't want to be going too low, particularly quite soon after the surgery. But we're going from a single leg sit to stand, so we're trying to keep that pelvis nice and controlled as we're standing up. All right, so like the pictures that Dr. Tudor was showing, particularly with the younger population and females, we often see the knee come in as we come to stand up. So we want to try and keep the alignment, keep the control as we come up, touch, and then back down. Would you like to have a go?
Yeah, I don't think I get it. What do you do? Stand up on one leg.
Yeah, so one leg out in front. Good. And then try and stand up without using your hands. Good. Good.
No, it's not easy. You want to go? Come on. Yeah, come on, Daisy. Stick one leg out. Oh, you cheated too.
Yeah, a little bit of a counter.
I need the counter.
All right, so the cheating mechanisms are the throwing yourself forward to have the momentum, using the hands obviously to come up, all right, and then obviously the tilt and the correct. So as well as leaning forward and then extending to stand up. So there are quite a few ways that people can cheat because there's so many muscles involved, which comes down to what Dr. Tudor was saying. It's not just about getting those muscles stronger that are associated with the surgery and the injury, but it's about getting the muscles stronger everywhere else that controls that movement. And that's what's going to get the patients back to sport, have a better quality of life and prevent further injury. And that's why it's important to have the physiotherapy ongoing. So not just those couple of sessions post-surgery to get them back walking around the home, fine, but to get them back so that they don't have injuries and regress down the track. Because as we all know, everyone gets weaker as they get older, and prevention's better than cure. Cool.
Excellent.
Is there any questions about any of that? Cool. Everyone realise how weak they are and how little pelvic control, well not pelvic control, but core control they have now? Good. We can all work on something now.
What's the vertical jump test?
So the vertical jump test is hands behind the back. And just literally trying to get as high as you can. Single leg, yes. And then similarly, and then there's the forward one as well as the lateral one is 40 centimetres over as many times as you can in, I think it's 60 seconds. If these aren't the pants to be doing it in. Thank you very much for my models. Thank you.